appreciate for part of our diabetes team to talk a little bit about students with diabetes. We'll be starting school next week, and I know on behalf of their families, they really appreciate that you've taken the time to participate in this education, and we can ensure they have a successful school year.
Next slide. Oops. Okay, I'm looking for it. I think this one's going to be slow, so just bear with us.
Okay. Do you know how to do that?
Can you folks look up, whoever has the computer there, up to the left-hand corner, and there's a picture of a microphone there. And if you would just click on that, it will mute your microphone so it's speaking in your own areas, then it doesn't kind of disturb anybody else. And if you do have a question, you can just unmute your microphone and, address the question, and we'll try to see what we can do with that. For those folks that don't have microphones, there is a text box as well, so that you can text a question, and we'll make sure that we try to address that as well. Okay? So, we go.
Okay, great. With our first slide, in our health region that we cover, which now matches Anglophone South, which will be very convenient, going from Sussex to St. Stephen and the outer areas as well, we follow about 120 children with diabetes.
Okay. Yep.
And what sort of links our healthcare team at the diabetes clinic to the education system as well is Policy 704, and it defines the standards and procedures to ensure the health of our students with diabetes while they are the responsibility of the public education system. And this responsibility is shared three ways between the parents, the school system, and the healthcare providers. So for a student to have the best success in their educational experience, it is important that all parties work together to ensure diabetes control is optimal. So today's goal for our presentation is all school personnel should be able to identify students with diabetes, recognize the signs and symptoms of low or hypoglycemia or high blood sugar hyperglycemia, the treatment of hyperglycemia and hypoglycemia, become familiar with equipment and treatment plans for students with diabetes, and get to know the pediatric diabetes team to use as a future resource, because we do realize that sometimes school personnel feel like they're being taken out of their comfort zone with some of the diabetes management, and we just want you to know that both families and the healthcare team of that student are together here to support you.
Okay. No, we're trying to get it. Okay. It's I have the little roll around wheel going at the moment, so we're just trying to change the page.
Hi, it's Lynn from Sussex Corner. Can anyone?
Yeah.
Okay, we just can't get the split screen. We're not using the PowerPoint.
Okay. Do you have an answer for that?
Is that just one person, or is that everyone?
Well, we're a group of 5 here, but I mean, it's on my laptop, and I mean, we can see you speaking, but we can't get the
Okay, it's just you guys. Others are saying that they're okay with the split screen.
So with the group, I'd recommend you just quickly X out and try to get back in.
Okay.
So we have logged on when they were trying to share and you just missed the send outs.
Okay, so just go on off and come back on again?
Okay, I'll unmute and do that so I don't disturb you.
Okay.
Thank you.
Yep. Okay. So just talking to begin with, what is diabetes? Insulin is a hormone that lowers blood glucose, and it's made in the beta cell of the pancreas, and it's produced to assist in the movement of energy from our food into the cells of the body. And it's released from the pancreas in response to rising blood sugar level, and it's essential for growth. So children with diabetes have this type of diabetes, but it makes up a very, very small portion of the population with diabetes. Probably only 5% of people with diabetes have this insulin-dependent type. So we call this type 1, and that's the kind of diabetes your students would have. Now, I wonder if that's all that's on that slide.
No, it has like the, should be split, but should be another.
There. And when we talk about how does diabetes, type 1 diabetes come about, we really aren't 100% sure, but it seems to often happen at a time following a viral or an environmental trigger. So that child may have been born with a predisposition to develop diabetes, and it may come about at a time of rapid growth during adolescence. It can happen in toddlerhood following a bad virus, that it makes the immune system go into overdrive and see the insulin-producing cells in the pancreas as the enemy and attack them so that they no longer release insulin, and at no future time will they regenerate. With type 2 diabetes, once again the cause is unknown. It's usually seen in people over the age of 40. It has to do in a lot of cases with being overweight, although I will say some people with type 2 diabetes are not overweight. And usually there's a very strong family history of aunts and uncles and grandparents over the age of 40 developing diabetes. So type 1 diabetes is usually before the age of 30, and it's when the cells of the pancreas are destroyed and the body stops producing insulin. Type 2 diabetes, the body continues to make insulin, sometimes more than normal, but the insulin is ineffective, and it usually appears later in life. You are seeing it happen with childhood obesity in some populations, especially the native population here in Canada and Manitoba, but we are not seeing it in our area in New Brunswick. So a typical day for a student with type 1 diabetes is they're going to be checking their blood sugar at times before meals, such as before breakfast, lunch, before supper, and before bedtime, or any time the child is feeling unwell. And as far as insulin injections or insulin pump boluses, they would have insulin injections before meals, in most cases breakfast, lunch, supper, and bedtime. If they're also on the insulin pump, they would take insulin with snacks as well. And this is just a picture of a lancing device that could be used. Inside that pen, it has a little bit of a spring, so it's a trigger, and the lancet pricks the side of their finger and gives them the drop of blood that they need for their blood sugar meter. And this is a picture of a blood sugar meter, and as you're going to hear about later, what we're aiming for is blood sugars in the 4 to 10 and 4 to 8 range, so you can see this 3.6 is actually a low blood sugar reading. And this is what an insulin pen looks like. Inside the insulin pen is a glass tube of insulin called a cartridge, and that's changed every month or when it's empty. And the needle that's on the end is removed, and a new one is put on each time the insulin is injected. And this is an insulin pump, and it's a small programmable device that delivers insulin. And what it does is it eliminates the need for those daily injections, because as you can imagine, some children take 5 or 6 needles of insulin a day. With the insulin pump, they put a site in, and that's just changed once every 3 days. So a lot of families have taken the lifestyle choice to have their child go on an insulin pump. And in New Brunswick, we just in February had a provincial insulin pump program that's assisting children under the age of 18 to receive an insulin pump. They are about $7,000. And this is a picture of a tummy with a site in. Just so you know, the site is a very tiny little cannula that fits just underneath the skin and the fat, because that's where insulin is to be absorbed from. And that would be the site that would stay in for 3 days. And think of an intravenous, and it's just a miniature intravenous, but yet it's only going into the fat.
Just can cross. Is there anybody that has questions for Tara just now on anything that she said so far, or can we continue? No? Sounds like we're good. Okay.
Oh, excuse us, hi, we have a question.
Oh.
This is Corner Elementary.
Yeah.
Yeah.
Oh, I apologize. My question is to you is, with a student wearing an insulin pump, is there any risk associated with using that pump, or wearing that pump while you're engaged in physical activity? Like, is there any risk in possibly that pump being knocked off?
Okay, so.
Okay.
Yeah, I'll repeat the question for you. If I understand it, what you're asking is if there are any cautions or dangers or safety risks or anything like that associated with wearing an insulin pump in during physical activities and things like that?
No, it's just if there's going to be impact, like if it's, a football game or something like that, most cases the children just take their pump off. There's a way to disconnect it without taking the site out. And most cases, if they're swimming, they would take their pump off.
Okay. Any other questions so far?
No, we're good, thank you. Thanks for the note.
Okay, we'll keep going.
Okay. So a typical day for a student with type 1 diabetes, they would be following a meal plan.
I'm going to talk about that some more.
Okay. I'm just going to touch on this. Janet's going to talk about it more. They would do a meal plan or carbohydrate counting, which is essentially measuring the amount of energy that's in the food. Label reading, calculating insulin dose, or match carbohydrate targets. Specific times for meals and snacks are important, and the school routine is very much a benefit for children with diabetes. And I'm going to pass over now to Allison, and she's going to talk about high blood sugars and low blood sugars. Thank you.
Okay.
Just speak out loud.
Oh dear.
Okay, so the child with diabetes needs to balance the amount of insulin they take with the amount of food they've eaten and the amount of activity that they're doing to achieve a good blood sugar level, which for children in elementary school, we say between 4 and 10 millimoles. And as children get older, we try to target the blood sugar between 4 and 8 millimoles. If the balance is not quite right, blood sugar may be too high, which is called hyperglycemia, or too low, which is called hypoglycemia. So high blood sugar, or hyperglycemia, is caused by too much food, not enough insulin, not enough activity, or illness. So for example, if a child gave their insulin for how much food they were eating, and then they decided to eat more food after, and they've not had the insulin for that extra food, that can cause high blood sugar or hyperglycemia. Illness is a stress response that will often raise blood sugar as well. Other things that can happen, and it happens to the best of families, is that an insulin injection may be forgotten, at breakfast with the hubbub of everything that's going on. Child gets to school and blood sugar is very high. That could be a result of insulin that's been just forgotten. Treatment in school includes unrestricted water or sugar-free beverages and bathroom breaks as needed. This is just a little pictogram that is available for schools to have either in their classroom, especially if it's a child in the school that has diabetes, that gives you some examples of what a child might be experiencing with high blood sugar. So some of the symptoms might be dry mouth, extreme thirst, needing to go to the bathroom, feeling drowsy, their head is on the desk, looking pale is another complaint, frequent bedwetting, and I guess that's probably about it. Stomach pain is another one that children can experience with high blood sugar. And if we sort of look at what's happening in the body, is that there's excess sugar in the blood, and the body's natural response is to try and remove that sugar by the kidneys working overtime to get rid of it. So that's why they're needing to go to the bathroom. They're feeling dry and thirsty from all those trips to the bathroom. They're maybe getting a little dehydrated. So water, lots of water also helps to flush out that sugar, the extra sugar.
Okay. A question came up from someone as to whether or not we can get a copy of the poster, and I think we probably can for people, so I'll make sure I do that and get it out to you, okay? Oh, good, okay.
So what can we do about the high blood sugar at school? For a child on insulin injections, a blood sugar over 18 is what we sort of consider a high blood sugar. If they have nausea and vomiting, it's probably self-explanatory. You're going to be calling the parents anyway. So the child, if the child is not feeling well with nausea and vomiting, you'd want to contact the parents immediately. What you can do is the child should have free water, and most children would have a water bottle at their desk anyway. That's usually pretty acceptable. No strenuous activity. Strenuous activity can actually drive the blood sugar higher, so we don't recommend that. Check blood sugar sort of in 2 hours' time just to make sure it's not gone higher. And if blood glucose is still over 18, give the parents a call. Some children can have a blood sugar of 18 and feel perfectly well, and that's not a concern. But the parents need to just be notified.
Okay. I have a question from Michelle, and I think you've sort of answered this, but is 18 the norm, or does each child have their norms different? Hang on a second, I lost the question. Here it is. Is 18 the norm, or does each child have their norms for high and lows?
Well, low is, under 4 is a low across the board. 18 is a little bit of a gray area, and we use 18 in our clinic as a guideline for parents. When you're on injections, we tell parents you're not going to give insulin in between those meal times when the child's on injections. We would say if a child at 10 o'clock in the morning had a blood sugar of 18 or higher, we would follow these instructions, and then probably what the parent would end up doing is instructing the child to give more insulin at lunch.
Okay, and there's a question from Chris who says our policy says over 14 calls a parent. So
yeah.
So we would, if it's our policy for 14, then we have to,
yes. Policy 704 does use 14, and our clinic uses 18 for a child on injections, but if it requires a phone call home at 14, there may be no action required, but just a phone call.
Just follow the policy. So if it's 14 for us, then that's what we need to follow.
I think we just need to realize that it's not a medical emergency if a child is feeling well and their blood sugar is 14 or 18. Because what can happen often is, say a child has just received their insulin at 8 o'clock in the morning. and they get to school and they're feeling, you know, not quite right maybe, and they check their blood sugar, and all of a sudden it's 20, but it's only 8:45. The insulin hasn't had a time to start working on the food that the child ate at breakfast, and typically we wouldn't see that blood sugar come down for at least 2 hours.
Yeah, and Michelle's comment back to us was that you're medical professionals, we are not, so that makes sense, that we're just a little bit more cautious, right?
Yeah, we should just say that we weren't involved with this.
No.
Yeah.
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 Okay. So anyway, we go with 14, and that is cautious for us.
Yeah,
with that.
Yeah. But just so people know that, because it's not a medical emergency.
Right.
You don't send them
Yeah,
home
so-
with your blood sugar 15.
Right.
Yeah.
Okay. Does that make sense to everybody? I think? Yeah. Okay.
Most children at one time or another are going to have a high blood sugar.
Oops. Yeah.
Yeah.
Let's see the previous. Oh, just a minute. Here.
There. Again, with a child on an insulin pump, the same rules apply. If the child has nausea and vomiting, you want to give the parents a call and let them know. So with a child on an insulin pump, we actually tell our parents of our pumpers that a blood sugar over 14 is when you sort of have to take notice. So again, water to treat that high blood sugar. What a child on a pump can do is give themselves a correction bolus through their pump, whatever's been sort of agreed on with the parents. This would be something that your parents would be advising you on. And that once that correction bolus is given, the child should retest their blood sugar in 2 hours. And if the blood sugar has not come down, you should contact the parents. The things we need to remember about the insulin pump is, if the flow of insulin that is going into the child's body is disrupted somehow, like the site has been pulled out, or there's a kink, or there's something and the child is no longer receiving insulin, we will see a rise in that blood sugar. And parents need to know that there may be some troubleshooting they need to do. If a site ever does come out at school, parents should be notified that's something that will need to be put in sort of within the next hour or two.
Okay. I have a question from Bonita. What blood sugar level is considered to be an emergency? That is not just calling the parents.
And it's not really a specific blood sugar level. You're going to be calling the parents if their blood sugar is over 14. But the signs of a blood sugar that is getting into trouble is when the child is not feeling well. Yeah.
Okay.
So this is just another pictogram of what I've just said. And we have copies of these as well if you'd like any of those at your school.
And I can send those out as well.
That's the same thing, yeah. So, hypoglycemia or low blood sugar is more of an immediate, you need immediate action for that type of, whatever.
All right.
We need to deal with it right away. So what causes a low blood sugar is too much insulin or not enough food, or physical activity. So the child took their insulin, didn't eat their food, and the result is a low blood sugar. Physical activity can also lower blood sugar, and sometimes children need to be extra prepared, say before gym. Some of them may need to have an extra snack, or some may need to test their blood sugar before gym. This pictogram as well, we can send that to you, and that just shows some of the signs and symptoms of low blood sugar. So we've got drowsiness, we've got mood changes, headache, hunger, sweating, the child that looks pale and has their head on their desk, or the child that's on the bus and has fallen asleep. That might be another indicator that a child with diabetes may be having low blood sugar. symptoms of low blood sugar, just as,
Mood changes.
Yeah.
mood changes, yes. A child that's just crying over small things that is usually very agreeable. When in doubt, testing blood sugar is the best. So anything under a 4 on the blood sugar meter is considered a low blood sugar. And treatment of low blood sugars, I think this is just another, we'll go to the next slide.
Okay.
Yeah, and we can provide these to the school as well. And basically what you're going to treat a low blood sugar with is a fast-acting sugar, something that's going to work quickly and get into the child's system to raise their blood sugar. So we're talking about a half a cup of juice, like you might find in a junior juice box. We also have sugar tabs that are available. They're called Dex 4, or some kids carry candy with them. Just half a cup of regular pop.
That's it, as you can see it, that's the Dex
Those are called Dex, sugar tabs.
sugar tabs.
Anything else I should show you?
The mini juice.
The mini
Okay, the
juice.
mini juice boxes, the little sippy boxes as well. Anything else?
We're looking at treating a low blood sugar with 10 to 15 grams of fast-acting carbohydrate. So one of these little junior juice boxes, a half a cup of juice, typically has, I think, some of them are 12 to 15 grams of carbohydrate. If you're looking at a larger juice box, you can have as much as 24 grams in a larger juice box. And that larger juice box may result in a high blood sugar, so it's best to start with the smaller one. So you're going to wait 10 minutes and test blood sugar again. Make sure the blood sugar has come up above 4. If it hasn't, you're going to repeat the treatment again. Wait the 10 minutes and recheck the blood sugar. If the next meal or snack is more than a half hour away, the child should have a starchy food such as crackers, little cheese and crackers, the handy snacks, they're perfect. Some of the smaller granola bars, again, 10 to 15 grams of carbohydrate, just to tide them over until their next meal or snack.
Okay.
So again, this is called a moderate reaction. You want to treat the sugar quickly. You want to wait 15 minutes for the treatment to work and retest. And you want to let parents know that the child has had a low blood sugar reaction at school. Again, that's the treatment that we talked about. Children may treat on their own, may treat their own low blood sugar. Normally in the elementary school age group and middle school, the child will let the teacher know, or an adult, let them know they're not feeling well, and they'll test their blood sugar together and treat together. Again, 10 to 15 grams of carbohydrate, and most children will have 1 to 2 low blood sugars a week. Important not to leave the child alone. If the child is on the playground and says they're having a low blood sugar, the buddy system is best, either a responsible adult going with them, or if they're older, a friend or another child to go along with them. These are just some examples of what you might use or have to treat low blood sugars. So a moderate reaction is when the thinking process is now affected. So the brain is eating sugar and it doesn't have enough, and the child may need help to treat the reaction. The child may not be cooperative with the treatment. Very few children will ever have a moderate reaction at school if the mild reaction is treated quickly. So again, 10 to 15 grams of carbohydrate with assistance of an adult, juice or regular pop through a straw with assistance, or there are icing gels that parents can provide, the little cake made gels you can get at the grocery store directly into the cheek of a child, and blood sugar will come up. So once sugars are rising, a starchy snack should be eaten. Again, you don't want to leave any child alone. A severe hypoglycemic reaction is if the low blood sugar is not treated at the mild or moderate level, it may progress to a severe hypoglycemic reaction, and the child may become unconscious and may have a seizure. I don't want to scare you to death. It's been a very long time, I think, since the child has had a severe low blood sugar reaction at school. But just so you're aware that this is a possibility and that there is something you can do. So the treatment for severe low blood sugar reaction, and this is when a child is actually unconscious, is glucagon emergency needle. It's a glucagon injection that will be provided, the glucagon kit itself will be provided by parents. You're going to give glucagon, and then you're going to turn the student on its side, on his or her side in the recovery position, and call 911 and contact the parents. You're not going to give anything by mouth to someone who's unconscious. Once the child wakes up, you're going to give 10 to 15 grams of carbohydrate by mouth, if able. And then follow up with a carbohydrate snack if they're able to. This is just a picture of the glucagon, and I'll quickly go through. It is very simple to learn how to give, and typically each school that has a child with diabetes will have 2 to 3 people trained within the school to give glucagon if needed. So I'll quickly go through the demonstration. Actually, I think it's on the slide as well.
Oh, is it?
Yep.
Just in case. Okay.
So basically what you have is a syringe with sterile water, and then you have a vial that has the glucagon in the bottom. So what you're going to do is you're going to take your sterile water, and you're going to inject it into your bottle, and you're going to put all of the liquid in. Perfect. Next slide. You're going to gently rotate in your hands or through your hands. You're going to massage the bottle until the glucagon is mixed. And it doesn't take very long before the glucagon will be mixed. Then what you're going to do is you're going to draw all of the liquid out of the glucagon bottle. Perfect. And you're going to inject it in the large muscle on the front of the thigh, just as you would an EpiPen.
Michelle, did that answer your question? She said, are there any particular things we need to know about the glucagon injections? So I'm hoping that answered some, yes, she said it does, okay.
Okay.
That probably is a little scary for folks, so was there any other questions that anybody had out there about that part? Hopefully we'll never need that. Okay.
Right. Yeah.
They may not advocate their school for that reason, because the ambulance.
Right. So I guess I don't know if it's a policy. No.
Guideline.
It's guideline. It's a guideline. If your school is close to the hospital, or did we say 20 minutes away from a hospital or ambulance, there are some schools out there that don't have anyone trained in the glucagon. Yeah, so it wouldn't be in every school that everyone would require someone to be trained.
Michelle's also asking, where do we get Sharp's disposal?
Well,
The district.
I thought the district provided.
It's always in the district. Okay.
Yeah.
All right, I can look into that for you. So that's not something I know about starting out the year, but I'll look into that for you.
Yeah.
And we'll if you need one, we'll make sure that you get one.
Yeah.
Yeah.
Okay. Yeah. So, just in conclusion, supervision of students at school. So ensure the students have a clean, private place to check their blood sugar and give their insulin. Safe disposal of lancets, and that's the little sharp part that they're using to test their blood sugar. Their pen needles and anything contaminated with blood should go in the sharps container at school, or some children would carry little containers in their kits and bring those home with them. Ensure that students eat all their snacks and meals fully and on time.
Okay. I have a couple of questions here. Let me just go back. Okay, there's a comment, Lynn, about the disposal. Said I got some from Lawton's free of charge, and I can just change it up when it's full, so that there's a source for you. Stephanie, the question is, so you have to be trained for this injection?
You do.
Okay, and she said, who gives glycogen training? We're not trained. So I don't know if that is.
What school is that?
What school are you? That Michelle, you're at, I don't know where you are.
You know, there are a lot of schools where
Fundy High School.
parents will actually go in and do the glucagon training
With, okay.
yeah,
And Sussex Elementary's asking too.
yeah. So parents are certainly capable
Right.
of showing
How-
how to give that.
Okay.
Yeah.
Or local pharmacist. What I'll do is I will make your local coordinators, support services coordinators, aware that there might be a question about that. And, you know, a school could just give Brenda a call, or Marianne a call, or Helen a call if you're concerned about that, and they can make sure that that's covered for you somehow. Again, because a parent can do it, or a pharmacist can do it.
We can do it too, but the reality is,
Right.
we can't get to
Every school. So the nurses
Yeah.
can't get to every school, but there are ways that we can make sure that that's organized for folks, and if you're worried about that, that we can make sure that that happens for you.
Yeah.
Okay?
We also have a video as well that I'm wondering whether you can even view that online. It's just a glucagon DVD,
Okay.
but it's put out by the company that makes the glucagon. It's Lilly, and there may be something online as well.
Yeah. Just, yeah. Hold this back a little bit too, so they can see the face. That's the video. If somebody wants to go on the site, or I'll check it out this afternoon too, to see, there. And it said, Stephanie says, what about the rest of the class while all this is happening? That would have to be probably, you talk to that with your school team, you know, in the case that this is happening, this is your plan for that to happen.
Yeah.
So, you know, as a school, you can work together to figure out what your plan is going to be. Okay?
Yeah. No, and I'll just mention that the needle can go directly through clothing, so it's not like you need, you know, have the child's pants pulled down or anything. It can go right through clothing. Maybe not snow pants, but certainly jeans or whatever else they're wearing.
Okay? So are we on to the next?
Yeah. These are just some examples of sharps containers. So students should not be left alone for 30 minutes following a low blood sugar, during blood sugar testing. Now this is assuming sort of the elementary, and it's kind of questionable in the middle school stage. You're sort of getting to a gray area. Certainly once they go to high school, they are very much independent and doing their own thing. But certainly in the younger grades, whenever giving insulin by injection or pump, and when doing blood sugar testing, and making sure the child's eating their meals is certainly important. It's crucial in the elementary, and some children in the middle school grades as well. And again, mutual agreement between parents and staff, and communication between parents and school staff is essential. Children, and we know, children spend 30 to 35 hours a week at school, and complications like a low blood sugar can occur at school. This is a resource, and actually there is a new, it's called, that one, Standards of Care for Children with Type 1 Diabetes in School, and is available from the Canadian Diabetes Association. If anyone would like to have a look at that, it is at that website. It's called Standards of Care for Students with Type 1 Diabetes. There are no national guidelines for children in schools, so everywhere is just sort of provincial. Yeah, provincial. We're doing our own thing.
Question from Stephanie. Students, this is a question. So students have to have someone with them for lunch at all times? Does it have to be an adult?
If you're talking about a child in elementary school, they don't need to have someone standing over their shoulder while they're eating, but just keeping an eye, watching what they're eating, and making sure that they're eating all of their snack or lunch, for sure.
And for older children, they are usually looking after themselves.
They usually are, yeah. And this is just one of the technologies that we have available now. It's called a continuous glucose monitor, and it works in conjunction with the insulin pump. And basically, we have the pump site there that you can see, and then above that, it's called a glucose sensor that goes in to just the fluid under the skin, and it transmits a blood sugar to your pump every 5 minutes. So you can look at your pump and know basically what your blood sugar is at all times during the day. We don't have too many children that actually use this all the time. Each one of those little sensors is good for 5 to 7 days, and it's $50 each time you use one, and a lot of the health plans out there do not cover that. So it's not really accessible to everyone. Plus, it's also an extra piece, that a child has to wear at all times. We do have a few children that do wear it, and we have several people that just sort of wear it sporadically when they're having trouble managing their blood sugars. But that's our newest technology. And I will hand things off to Janet, our dietitian. Oh, we're good. Is that good? Yeah. Okay. Go ahead. All right, so you can go to the next slide. Yeah. Okay, so for diet for diabetes, when I first started working as a dietitian a million years ago now, there was this very strict diet, a long list of forbidden foods, and it was very complicated. Well, maybe it's still complicated these days, but all of the do's and do-nots and the forbidden foods, that's all gone by the wayside. So now a diet for diabetes is a healthy, well-balanced diet. There's really no foods that are forbidden. There's some foods that have to be carefully planned and worked into the meal system at certain times, maybe when insulin's being given or at a meal time or another time. But there's really no food that we would say, no, you may never eat that again. There's a number of different systems available for matching up the amount of insulin with the amount of food that children are eating. And as you listen to Tara and Allison, you realize that there's a lot involved with getting that right value with the blood sugar. We don't want to be too high or don't want to be too low. A number of systems that contribute to matching the food to the insulin. Next slide. So this is just Canada's food guide to remind everyone that we all should be eating according to the national guidelines, and that would include kids with diabetes as well. However, if I go to the next slide, and you can just skip on to the next, beyond that, yeah. The Beyond the Basics food guide is made for people with diabetes, and so the food's broken into slightly different groups. And we would use this information based on the amount of carbohydrate each food contains and use that to match up with the insulin and blood sugar. So the first group that you're seeing here are the grains and starches, and that would include any food that was made from a grain, a flour, or starchy vegetables. And one serving of any one of those foods is going to give the equivalent of 15 grams of carbohydrate or like 3 teaspoons of sugar. In the next slide. Then these are additional foods that have carbohydrate in them. The fruits all have carbohydrate. Milk and alternates have a carbohydrate. And then the last category is other choices, which is a lot of sort of treat foods a lot of time. And each one in one portion size, as listed on the guide, would give the equivalent of 15 grams of carbohydrate or the 3 teaspoons of sugar. So the kids would all, their families would all learn this food guide and would get a sense of how much carbohydrates in the various portions of food. Turn the next slide. So the last slide up here are the foods that would have very little carbohydrate, or the carbohydrate in them would act very differently and not have to be balanced with the insulin. So there you're looking at the vegetables, meat and alternates, and fats and oils. So a lot of times kids will talk about, well, that's a free food, or I don't have to count that food. And those foods that they're not counting or that they're free, they may in fact be free of carbohydrates, what the children are saying, and they wouldn't have to balance those foods along with their insulin. So for example, if someone's eating their lunch and they've got cucumber slices and they say, well, I don't have to eat that because that doesn't count. Well, it would have no carbohydrate in it, so it wouldn't have to be matched up with what they're having for their insulin. Next slide. Okay, so there's a number of different ways of balancing that out and managing that. More old-fashioned would be a meal plan, which used to be used a lot, and it's very seldom used anymore. And that would be a very rigid set plan. So breakfast would always be the same food, lunch would always be the same food, supper would always be the same food, and then it would be measured carefully and then given with a set dose of insulin. So lunch would always be a sandwich, piece of fruit, and milk, and there'd be no deviation from that. As you can imagine, it limits people, and it's not very popular because it doesn't have a lot of flexibility to it, and it doesn't really match up well with real life. So most people are going now to a carbohydrate counting or carbohydrate targeting approach, where they're actually adding up the amount of carbohydrate in each meal and then balancing that out with the insulin they're taking. Next slide. So when you're looking at, I've already said that. Next. Okay. Skip that one. Okay, so carbohydrate counting, you're matching the insulin dose you're giving to the actual amount of carbohydrate that's in the food that's being eaten. There's a lot of variations on the theme, and I think every family I talk to that's carbohydrate counting does things a slightly different way. But the bottom line is you're trying to get as close a match as you can. Next slide. So carbohydrates, there are broad categories of carbohydrates that are in our foods. Sugars, the ones that we might think of first. Starches, of course, digest and turn into sugar in the blood system. Fiber is also a carbohydrate, but it's one that we don't absorb. So when the kids are label reading, and I would not expect teachers to be having to do label reading, but they may be interested in this, the kids would be subtracting the amount of fiber that would be in a particular food on the label from the total amount of carbohydrate, because even though it's a non-absorbing carbohydrate, it's included in the total amount of carb on the label. And the last category of carbohydrates are sugar alcohols. They're generally food and found in like diet food, diet cookies, diet candy, that sort of thing. Not too common. They don't absorb either, so the kids would subtract any sugar alcohols off the carbohydrate total as well. Okay. So each system of carbohydrate counting is going to use some way of measuring the food, some way of estimating the amount of carbohydrate in that food portion that's going to be eaten, and then some way of matching that up with the amount of insulin that will need to be taken. And next slide. Okay, and so the insulin dose for someone carbohydrate counting can be changing from meal to meal. So they're calculating that dose each meal as they eat. So, for example, if you're having a pasta supper, you're having spaghetti and you're having garlic bread and you're having fruit for dessert, that will have significant carbohydrate. The person would take much more insulin with that meal than if they were having a meal that was much lower in carbohydrate, maybe barbecue chicken and a salad and a bread roll. That's going to have a much lower dose of insulin. So the system of trying to titrate the insulin to the amount of carb. When the system is working well, things are being measured carefully, and it's fine-tuned, it can really work very effectively to control blood sugars. Next. So for getting the information about carbohydrates in food, families would use label reading, which is one of the most common. They'd be going to food tables. They'd be, there are all kinds of different apps out there that can do carb counting, plugging in the numbers. There's a number of different averaging systems available. So they're gathering a lot of information from a variety of sources to get those numbers. Next up. So some families would use what we call carbohydrate targets. So they would have a target they're aiming for. So maybe a particular meal is going to be 45 grams of carbohydrate, and that they're going to choose foods that are going to give their child about that 45 grams of carbohydrate. And then they would take that with a set dose of insulin.
That's a little bit simpler for a lot of families. Some families would take the amount of carbohydrate that's going to be consumed at the meal, and then they have a mathematical formula they use with a ratio to predict the amount of insulin they need. So then there's a little bit more math skills, a little bit more multiplication, division being involved in that. Next one. So this is just a simple example, and this would probably, from the amounts there, it's probably quite a small child, but if we had a meal that was like 2 fish sticks, the breading on the fish would count, so it'd be about 15 grams there, maybe 10 French fries from the oven, that's going to be about another 15 grams of carb, maybe some raw veggies in the dip, maybe the dip's got something in it, it's about 3 grams of carb, glass of milk, another 15 grams of carb, so that might be around 45 grams of carbohydrate. So for the one that's doing a target, that's going to be like around that 45 to 50 target they're aiming for, and they take that with their set dose of insulin. If they were using a ratio, and maybe they're taking 1 unit for every 10 grams of carb, you take the 48, divide that by 10, and then 1 per 10, it would be 4.8 or round up to 5 units of insulin for that meal. It's a fair bit of math. So, things that happen at school. I know some schools have a no trading policy for lunches, that everyone takes their lunch and eats what they brought. That's fabulous for diabetes. Other schools that can't happen, and you know, it's difficult. But certainly anytime there is a no trading policy, that's good. I hear from a lot of the kids that by the time they go and check their blood sugar and take their insulin and get to where they have to eat, that they're really rushed to eat, because I know people are on a really tight schedule. But to give the kids enough time to eat is really important, if that can be somehow built into the schedule. And as Allison had mentioned, encouraging kids to finish their meals and snacks. Now, there's nothing you can do if someone refuses to eat their lunch, but certainly letting the parents know what's happening is going to be helping. And then timing of meals. Diabetes does not work well with surprises. So having a meal shift an hour or a snack shift an hour through the day is really going to throw things off for a lot of kids with diabetes. Good communication with parents is absolutely essential for any children with, well, for any children, but for any children with diabetes. So if there's going to be any kind of a special event or activity that you know about in advance, if you can let the parents know, then they can work to build that in so that their child can participate. School lunch programs, menus that are happening, if you could communicate any things that are going on there, that just makes life so much easier. And saying like, is there going to be a surprise or a food treat or a party, the more you can give the parents information ahead of time so they can work it out so their child can participate, because almost everything can be worked in. But if it's a surprise, a lot of times it can't be worked in at the last minute. Other things. Teachers and helpers in the classroom may be asked to confirm calculations. Like I say, little guys just don't seem to get the whole decimal thing, so a 1.3 and a 13 are all kind of the same to them, and there can be some big errors made. Math skills are absolutely essential for people with diabetes who are doing carb counting. So, and I know that there's a lot of issues with math skills for right across the board, but the more that we can build up math skills on all of our kids, the better it is. And then good communication with the parents, and if you're seeing things happening at lunchtime, letting the parents know, that's really helpful. As Alice has mentioned a little bit about exercise, but extra activity can increase the amount of the effect of the insulin that's happening in the blood. So, in fact, extra food may need to be eaten before a particular exercise or activity. So, for example, some kids, when they're going to go to gym class, may need to have a little snack or a juice before they go to gym class to give them that little bit of extra sugar to balance out with what they're going to be using during the activity. Pumpers, they may have to do something different with their pump. They may have to, if they're going to keep it on, they may turn it down a little bit, so they're going to have a little less insulin in their system. So there's a number of things around activity and exercise and diabetes and food. It's really essential to talk to families, because every child's a little different with what they need to do in order to achieve a good balance. Okay. If there's going to be any kind of a change in routine of an activities plan, letting parents know ahead of time is really important. They may need to change a long-acting insulin, maybe even the night before, to accommodate an activity the next day. And then as well, with activity, allowing the child to eat or drink as they need to before the activity and during the activity is so important too, to try and keep that balance going. Okay. So in summary, every child with diabetes is going to have an individual system that they've modified to suit their own needs and what's going to work best for them. And the other thing is children get older, they're going to be changing as well. So those systems are going to have to change and adapt along with the children grow. There's no food out there that I would consider a forbidden food for kids with diabetes. So everything can be worked in, given enough planning and calculation and time. And scheduling is so important. Diabetes doesn't work well with surprises at all. Kids with diabetes need really strong math skills, so the more we can encourage for everyone, but especially kids with diabetes, and good communication is so important for parents. I think that's it.
All right. Yes. Here I am in that thesis. Hang on a second. Sorry about that. There we go. I think this is me. That's the end of the presentation. Are there any questions that you would like to ask either the nurses or our dietitian here before we finish up with the presentation? Don't see any. Okay. Thank you very, very much for sitting in on the presentation, and we will thank the ladies for their speaking to us this afternoon. Oh, here comes a question. Oh, that was excellent, they said. So. It's a new experience for us all, too, so thank you very much for being patient with us all, and again, thanks for the ladies. Thank you very much. See you later.
Zone. We don't use zone anymore. Maybe someone else has taken it.
We get some for each. Did you want this? Yeah. Did that one come from this file?
I think this is 2008. It's 2004.
Oh, yes. Okay. Didn't notice that. See, that was the green copy, and I thought that this was the. Okay.
We can update.
No, right. Yeah. I'm not sure we have the actual. But this handbook on standards of care.
We're getting lots of thanks from people. So.
Oh, that's so cute. Well, it's nice it's recorded too, because
people have listened. This is the first time I've ever done a webinar from this side.